Okay, non-invasive ventilation. Non-invasive ventilation is essentially, when we're using the servo, works basically the same or the same principle as the Respironics Visions. And what do you use, Visions, or do you use the V60s, the newer one?
We're going to use it.
V60s? Okay, in the Vision. So the idea is that you're delivering a positive pressure by a mask, and a lot of the medical literature now is suggesting that we should try harder than we have in the past to ventilate patients non-invasively rather than just, okay, let's just put a tube in. Because the minute you put a tube in, you can potentially inoculate the airway with bacteria. You create other complications with mechanical ventilation, intubated mechanical ventilation. So when we can, we should try to do non-invasive. The problem has been, well, it's harder to provide effective ventilation non-invasively because of patients' airways, because of their because of the interface, primarily the mask that we're using. We can't get a good seal, so therefore we can't get good volume. We also have issues with air going into the stomach and those type of things. As we improve the interface, that has helped in terms of our ability, and also the increased amount of education put on the fact of, hey, do we really have to intubate this guy? Can we see if we can get him over the hump by using a mask on him first, and then if it fails, then we will have to intubate, or maybe we can get the tube out of him sooner if we have a reasonable appliance to use with him and a reasonable ventilator to use with him. So that's the premise of not using non-invasive, because it will help your numbers in the long run in terms of, you know, infections, nosocomial infection, VAPs as we're calling them, that kind of thing. So in order to use non-invasive, as you guys know, you know, you have to put the ventilator in standby, and then simply take the same tubing and take the endotracheal tube off the same tubing if we're taking that patient that we just extubated but still needs some support. So and then take a mask and put the mask on the Y connector, and you're good to go with non-invasive ventilation. Now, the thing about non-invasive is, one requirement that the servo has is that you have to use a non-vented mask, of which this is not a non-vented mask. So this is a good example. So when you're using the servo, don't use this mask.
You're right.
Don't use this mask. Don't use the mask that has the flapper valve in it and the hole there. What happens is that if this flapper valve were up there and kept there because of you had an adequate amount of pressure underneath the mask, then you could use this mask. But the problem is sometimes this falls down and the patient begins to breathe or exhale through there because there's not enough pressure in the system, or it's kind of moving up and down but never including that. So what happens is the ventilator doesn't see the exhaled gas coming through the expiratory side of the ventilator, and it will give you constant alarms. It will give you alarms and auto cycling because the gas is leaking out through there. So you could, if this is the only mask you had in an emergency, you could make it work, but you just have to keep an eye on that flapper valve to make sure it maintained and created a seal. That way this is just like a non-vented mask. But typically you'd want to use a non-vented mask that has a blue elbow. On these Respironics masks, it's a blue elbow. And when it's a blue elbow, you just put it here the same way, and then you can use this for non-invasive ventilation. The biggest thing about non-invasive ventilation is to find the right size mask for your patient. This is nice headgear as well to use for your patients, so they're fairly comfortable. The problem with using masks on patients is you have patients with no teeth, beards, you can't get a good seal, so it's always leaking, and you have a significant amount of asynchrony associated with the delivery of the non-invasive pressure breath. You know, so that contributes to the patients being non-compliant with your therapy, meaning not lung compliance, but just, I don't want this, and they keep fighting it or struggling with it, and the mask keeps coming off, that kind of thing. And so you go, oh, we can't ventilate them properly, so let's put a tube in, sedate them, and no, that's what we used to do in the old days. So, so anyway, Non-invasive, the ventilator has to be in standby, so it's in standby, we simply go to the non-invasive button, and now we're in, and compliance compensation is turned off because you can't have compressible volume measurement in a closed system, or I mean an open system. It has to be in a closed system. The screen changes color to this burnt orange, as we call it, or this orange color. Now we're in non-invasive, and within non-invasive now we have, actually on this ventilator we have 3 modes, non-invasive. We have non-invasive pressure control, non-invasive pressure support, and then non-invasive NAVA. But the non-invasive NAVA is actually the best of both worlds, because with non-invasive NAVA, all of the issues that you have with non-invasive ventilation in terms of leakage, in terms of mask fit, that they don't all go away, but they're minimized to a significant degree in terms of using non-invasive ventilation when you have NAVA. And the reason, and I'll stop here, the reason is because you're firing the ventilator by using the diaphragm rather than trying to diminish or turn the ventilator off based on a diminishment of flow. Okay? So if the diaphragm turns on and off, and that is turning the ventilator on and off, it doesn't matter how much of a leak you have. I mean, you can't have the mask out here, it's not going to ventilate them, but you don't have to worry about leakage as much. The ventilator will turn on and off, and you can get much more efficient ventilation with non-invasive NAVA than you can with regular non-invasive ventilation. So to start with, let me just go to non-invasive pressure control as the first mode to start with. And non-invasive pressure control, you see the default parameters are lower than we would in pressure control, but keep in mind that non-invasive pressure control ventilation is essentially the same thing as regular pressure control, whether you're intubated. I mean, the parameters are the same. The ventilator has to deal with certain aspects a little bit differently, but from the standpoint of just a general description of what ventilation is, it's no different than invasive pressure control ventilation. We have a pressure control above PEEP, we have a respiratory rate, and we have an I time that we set. So in this case, the pressure starts off relatively low, which is a good thing, because in non-invasive ventilation you always want to start, regardless of where you think you're going to end up with pressure control, with your value, you always want to start on a relatively low setting so that you can get more patient cooperation. Because if you start off at a pressure of 10 or 15, maybe that's where you're going to end up, that amount of pressure under the mask has a tendency to agitate or get the patients excited initially. So if you want them to be more compliant, start off low and then titrate your pressure up as they become used to what you're doing to them in terms of this non-invasive pressure. So for the in-service though, I'm going to bring this up a little bit more so I just get a little bit more volume return. So I'm going to start my pressure control above peak. It's worth mentioning at this point we have terminology issues that between the older technology, the Respironics, the Visions, and those type of ventilators, where physicians order, put them on non-invasive, put them on 15/5. So the question is, what does that mean to respiratory therapists? What does it mean to a physician? What does it mean to a nurse? So what does it mean? If I were the doctor and I said, put this guy on 15/5. What does it mean to you in terms of a setting? Where would you set my pressure control level if you wanted to set them on 15/5? As kind of a tradition, a physician would say 15/5, and in his mind he's thinking exactly what you said, that the highest pressure he wants to see is 15 centimeters of water pressure. Right. So because we know how this ventilator works, we have to set a pressure differential, which is why we set 10. Because 10 on top of the 5 gives us a PIP of 15. Now I think on the other machines, you're setting an inspiratory pressure or a limit, and you would set 15, you would set 5, but the ventilator would only go to 15, which means that it would still be delivering a pressure differential of 10. And on some of the more sophisticated machines, you might have a little window that says pressure support or differential or something that would say 10 in it. But the doctor comes up and goes, oh, okay, I see you've got him on 15/5. Good, that's what I ordered. But if you have a young physician that was raised on this ventilator, or another, the Dragers or the other that do the same work the same way, and he says 15/5, and he comes up and he only sees 15 as a PIP on top of 5, he goes, I thought I told you to put him on 15/5. I go, I did. He says 15. I said, no, what I mean is I want a differential of 15. So I expect to see a PIP of 20, right? So in that case, you would set this at 15, and the PIP would be 20, right? So it depends on the culture, depends on, how things have been.
How smart your doctor is.
Right, right. And also, and really how smart the therapists are, because explaining this to some therapists, their heads explode in terms of, I don't get this. I don't get this differential thing. I always used to set an inspiratory pressure of 15, and I don't get this. Why do we have to do this? What's wrong with your ventilator that we have to do this?
No, it's on every ventilator.
It's every ventilator, right? And it's on and a little story behind this, not to take up too much time, is if you go back to the NICU world. And go back to the baby bird ventilators and the bird VIPs and those and the Seacrest and the infant star ventilators. When we would set, say, okay, let's put this baby on 18/5, what we would do is put our finger over the Y connector and then turn the pressure limit until we saw the needle go to 18, and then we dial in the PEEP and so on down to 5. So we would be 18/5. But once again, what is the differential? It's 13. So those ventilators you could call them flow interrupters. All they were was a big flow meter that you turn up to 6 liters per minute, and then at the end of it you had this little expiratory valve that would close 30 times a minute or whatever for a baby's rate. And when it closed, the flow, the 6 liters per minute, would be diverted into the patient. But 6 liters a minute going into the patient, and you had a timer on it, said, okay, let's deliver that for 0.5 seconds. Even 6 liters per minute at 0.5 seconds would deliver a tidal volume of 100 cc's or so. So you wouldn't want 100 cc's going to a 2-kilogram baby. So in addition, you'd have a little pop-off. So what you would do is you would set that pop-off so when the 6 liters per minute, when the expiratory valve closed and the 6 liters per minute had no choice but to go into the patient, once the pressure built up to 18 centimeters of water pressure, that would be vented out the pop-off, and then for the eye time, and then go back to the 5 a peep. So we learned then to set 18/5 or whatever was ordered in that case. That translated now to some of the earlier ventilators that had pressure control on them, but in our thinking anyway. But the very first ventilator that had pressure support where we had to deal with this issue was the Servo 900. That was the very first ventilator that had pressure support on it. So when that came out, once again, this is a historical perspective, when pressure support came out, it was like this new mode that we would say, yeah, it's pressure support, and we would describe it in various ways. So when you want to use pressure support, set it at 10. And they'd say, okay, well, we'll set 10 of pressure support. But when they looked at the PIP, what are they going to see? 15, because they're already on a PEEP of 5. But the thinking then went towards, in pressure support, setting an absolute value, saying, okay, I'm going to set 10 of pressure support. There was no discussion about, well, set his pressure support at 15/5. We didn't say that. We just said set his pressure support at 5. And then when his PIP was observed, it would be 5 plus 5 is 10, right? So we created this monster ourselves in terms of not really understanding what we were doing with pressure support ventilation. And it created all this confusion out there amongst all the manufacturers and all the respiratory therapists and the doctors in the whole world about trying to define. But once again, pressure, you were talking about the differential. And that's all we're talking about.